Hello and welcome everyone to this Ask the Expert webinar this evening. My name is Paula Hanford, for those of you who don't know me, and I am the CEO of PSC Support. This is a rescheduled webinar from last week. We were due to have this webinar last Tuesday evening, but we had some technical difficulties. Dr. Culver was in the waiting room. We couldn't see her and she just couldn't get it. We just couldn't get her in. So I want to apologize yet again for last week. We've spent a lot of time this week trying to make sure that doesn't happen again. As you can see, we have Dr. Culver on with us already. So that's brilliant. One of the good things that came out of us not being able to have the session last week is that our numbers of people who've registered for this webinar have actually doubled. So, which is crazy, but it's really good because we can bring this research webinar to more people affected by PSC. I am delighted to be joined this evening by Dr. Emma Culver. Dr. Culver is a consultant hepatologist and senior lecturer at the John Radcliffe Hospital in Oxford. Dr. Culver has a special interest in immune-mediated liver disease, and she is one of the leading PSC experts in this country. This session is about PSC research. It's something we are all hugely invested in, something we are all hugely interested in. And Dr. Culver has just returned from EASL, which is the European Association for the Study of the Liver in Vienna, where I think there was about 6,000 clinicians at that event and researchers at that event, and so she's able to give us the most up-to-date position on PSC research. As always, I'm sure you will join me in thanking Dr. Culver for giving up her evening and for giving up her evening last week and for doing a practice session with us as well to make sure we could get her on. So, she's been very generous with her time for us. As always with these sessions, please put your questions in the Q&A section of the box that I can see in front of me, which I'm sure you can as well. As always, again on these sessions, Dr. Culver cannot answer your individual medical questions, but she'll answer the questions in the best way that she can. So, without further ado, welcome, Dr. Culver. Thank you so much for giving up your time this evening. We are really grateful. And I know you're going to give an outline on the research, and then we are going to take questions. So over to you.
Thank you, Paula, for that kind introduction. And hello, everyone at home. I think, as she mentioned, I'm very much going to try over the next 10-15 minutes to give you a little bit of an overview of the updates both at the European Association for the Study of Liver conference and also the BSG, which is the British Society of Gastroenterology conference that happened almost simultaneously over a week's period. Some highlights in other areas of research which I think are important, and then over to you for questions and seeing if I can answer as many as possible during the course of the hour. So I'm just going to share my screen and open just a pre-prepared talk just with some slides. And feel free, if you want to stop me, please do, but I will try to whip through these and explain them as best possible. And then, as I say, open to questions at the end. So the title I've kind of given myself here is just to talk about the research landscape in the context of PSC. And so over the next 10 to 15 minutes, cover some of the highlights that came up, as I said, in the European and the British conferences. And some of those highlights included looking at population-based studies, highlighting about how common PSC and IBD is now and what the predicted prevalence is going to be in the future, and how we manage that with regards to service demands and obviously growing interest in trials and research. Talking a bit about the guidelines on PSC care that we know that were produced by the European Society last year, and where patients feel there are gaps in the care that they receive and how we can go about making those better. Talk a bit about the clinical trial landscape with a particular focus on what we call phase 3 trials. So that are trials whereby we're pipping against what is standard of care, and we're looking at efficacy and safety of new treatments in a slightly longer study to those of phase 2. and talking a bit about the progress we've had with them and some interim results and what they mean. And then also trying to tackle a little bit about cancer surveillance, which I know is a very important topic to people, and thinking about novel biomarkers and whether what we currently do is actually working. And lastly, again, just cover what's on the horizon and the direction of travel that I think we are in. So if I start by talking about what is the current and future predicted prevalence of PSC and inflammatory bowel disease, there's a slide set here that were created from the International Liver Conference, so I will acknowledge them specifically. And the aim of this study specifically was to look at how common the disease is and how common it might be in the future. And the team used a nationwide population-based health administrative data set. And you can see on the graphs on your right-hand side here, you can see observed, which is the dotted line, and forecast, which is the line where you've got some blurring to the left and the right. And over a 5-year period, you can see that actually there is an increase in the patients' numbers who are going to have PSC with IBD, which is actually over and above those patients who just have IBD alone. And when we look at the figures of that, which is on the next slide on your left-hand side, actually we realize that over that 5-year period, the number of patients will increase from 5 per 100,000 to 7.8 per 100,000, with additional 12% of patients diagnosed within the 5 years following PSC presentation. And on the graph on your right-hand side at the very top, you will see patients who have PSC and inflammatory bowel disease. The 3 at the bottom are those patients who have inflammatory bowel disease on their own. And the first graph divides them by the type of inflammatory bowel disease, the second graph by gender, and the third graph by age. And overall, it's actually more likely that men are going to increase more than women, that those patients who have an indeterminate or Crohn's disease phenotype are actually going to increase over those with an ulcerative colitis phenotype, and those in the sort of 30 to 40-year population are going to have the highest increase in terms of age, whereas it's very similar across IBD. So we expect by 2027 there to be 11.7 per 100,000. So, doubling the amount overall that was predicted back in 2015. So there's going to be an estimated 3,600 patients with PSC and IBD living within the UK. And that's going to be independent of the IBD increase. And I guess that's going to increase our service needs. It's going to increase health utilization. And it's important for future planning, not just thinking about therapy, but also thinking about how we try and understand actually what's driving PSC and IBD, and whether or not it's actually just our ability to recognize PSC early on in the patients with inflammatory bowel disease, or there are specific environmental or microbial triggers that we need to identify in those subpopulations that are driving this overall prevalence increase. So that was the first headline from EASL, and I think it's important to understand that our requirements and our needs will be increasing, and this is becoming still a rare disease, but a less of a rare disease over time. The second focus is very much on the EASL practice guidelines that were created for primary sclerosing cholangitis back in 2022 and published. And there was a nice oral presentation and poster presentation looking at the reported gaps in what the EASL recommendations say and what patients feel that we are providing with regards to meeting these recommendations. So the aim of this study was to look at the patient-reported quality of care and to identify gaps within the current practice within Europe in patients who are not transplanted who have PSC. And you can see the methods in a flow diagram on the right side. So this is an online survey hosted on the EU survey platform. It was in 11 different languages and it was put out over a 4-month period. And there were different questions asked about the disease, symptoms, treatment, investigations, and quality of care. And the answers were grouped depending on the age of the participants who responded. And overall, there was a huge response rate of almost 800 patients. And the things that they looked at on the left-hand side, you can see on the graph, is whether or not colonoscopy was ever performed, the regularity of imaging, such as ultrasound, MRCP, whether or not there was FibroScan done in terms of elastography, and whether or not there was any bone density looked at. 86% of patients reported that they had at least one symptom during the questioning. A quarter of patients had never had a FibroScan or never had elastography. Half of the patients claim that never had any kind of bone density scan, even though they may have had a bone profile taken. 8% of patients have never had a colonoscopy, and indeed 15% of those who did have IBD and were due to have a colonoscopy on a yearly or 2-yearly basis were not receiving it. And whilst 40% of patients were invited to partake in a clinical trial, that means 60% of patients were never invited to partake in any kind of clinical trial or research. It went on to look specifically at therapy, and I guess the main highlights there were that actually 90% of patients in France, Netherlands, and Germany do receive ursodeoxycholic acid, compared to about 50% in the UK and Sweden. I guess I'll make a note there to say that we know that ursodeoxycholic acid, which is, a bile acid, has been shown to potentially in some patients reduce the alkaline phosphatase, but what that hasn't been shown to do is actually have any improvement in terms of long-term survival or clinical outcomes. And in fact, in high doses can actually cause significant problems. And so opinion is divided as to whether or not one gives ursodeoxycholic acid, particularly in the context of clinical trials. Reassuringly, 90% of patients did have confidence in their care and the care that was being delivered, although 50% of patients wanted more information, particularly on disease prognosis and the role of the diet and microbiome. And I think, a big elephant in the room is that actually itch was reported in 60% of patients, but only 50% actually got any medication for that. And it wasn't really teased out whether or not patients had not been asked about medication or whether they just didn't want it. But interestingly, over a quarter were given antihistamines, even though we know that cholestatic itch is not histamine derived or driven. And so whether they were given that for other reasons, it's difficult to know. But we know that antihistamines can often be quite sedating and actually can cause problems with fatigue that's associated with PSC and not necessarily help the PSC-related itch. 13% of patients were on rifampicin, but actually the new algorithm via EASL in terms of recommendations of itch, which I've put here, includes bezafibrate currently as first line with rifampicin as second line, and there was no mention of bezafibrate in the survey report. So I think in terms of the headlines, looking at both of those slides, actually we're probably underperforming, particularly when it comes to ensuring that patients have regular surveillance scans, they have regular bone density, and also they have regular colonoscopy. And I think it's important to empower patients to know what they should be asking for on a regular basis. And also, if they're not having that, just inquire as to why that is. And also the options that are available for them in terms of patient symptoms, and particularly a focus there on itch. And lastly, there were a number of quotes, and obviously one of the quotes are here below. There was a number of quotes, and I think these quotes are quite important because it really highlights what patients are feeling. So this particular patient from France said, "I want to know the vital prognosis and life expectancy for these diseases because on the internet, the data is old and frightening." And I think that's really important because actually what we do know is that there is a lot of outdated information and we need good places to signpost people for information, and PSC support is one of those. So the next thing I'm going to move to is sort of things about therapy. And in terms of therapy, I think broadly we can divide the therapies that are being developed for PSC into kind of 4 main areas. And that is those therapies that target the immune system, those that target the fibrotic or the scarring pathway, those that look at bile acids and the response of the biliary epithelium, and those that target the gut and the microbiome. And it's not that we work in our silos and we just target one particular area, because some drugs target multiple areas. But I think in a sort of broad level, that's the way that a lot of these therapies are thought of. And I've listed some of the drugs below there just for your interest in terms of the drugs and where they fit into in terms of their categories. So there's loads of studies to discuss, and I can't discuss all of them. I get the kind of key outlines here are the phase 3 trials. So the phase 3 trials that were discussed include the Primis trial, Nuke-5, Belsazar, and Piscatin. So a phase 3 trial is basically a trial that assesses safety and how well a new treatment works compared to standard treatment. And as you notice with all of these therapies, actually they're all of long duration. So these are not 12-week studies, these are 2-year, 5-year studies. There's large numbers of patients. And as I say, some of them are suspended now or finished recruitment, and some of them remain active. So the first study that was highlighted as an oral presentation was one that looked at Chyloflexor, which was a randomized trial, a phase 3 trial. And it's an FXR agonist. So essentially it's a semi-synthetic bile acid. And this was based on some early data that showed that this drug against placebo, and you can see the graph on the left-hand side, improved the alkaline phosphatase level, so that's the level of liver biochemistry, in a dose-dependent manner. So we went on to do a phase 3 trial, and the phase 3 trial, the intention was to recruit 400 patients and divide them either into placebo or to get the drug at 100 milligrams orally, because 100 milligrams gave the greatest alkaline phosphatase reduction. But rather than have the primary endpoint as the alkaline phosphatase, ambitiously, we looked to see whether or not there's a possibility of it actually causing stopping of fibrosis or even regression of fibrosis. There was no alkaline phosphatase cutoff for entry, and the endpoint was this evidence of fibrosis or scarring. And there was a futility analysis put into there, which basically said, if you didn't reach the more than 10% at a certain time point, actually the trial will be terminated because we won't reach that primary outcome. So these are the two tables of results. And essentially on the left-hand side, you can see the baseline characteristics. So mostly men, most of the patients had inflammatory bowel disease. The median age of the study was around about 40. And whilst patients didn't have a high liver stiffness, you can see by their fibrosis stage, they were quite fibrotic on entry into this trial. So 50% of patients had what we call F2 or F3 fibrosis. And actually, sadly, the study was actually terminated early due to a low probability of meeting the primary endpoint. And you can see the primary endpoint is the first line of this table on the right-hand side, which is a stage of increase in fibrosis. And you can see each of them were relatively equal. Even though overall, actually, we saw that the transaminases got a little bit better, maybe even there was a small but non-significant signal in the ALP. And importantly, it was well tolerated, even though we do know the FXR agonists do cause itching in 50% of patients and reported a degree of pruritus, but then stopped for that reason. So I think the key things to say here is, one, it was a well-tolerated drug. Sadly, it was terminated due to the low probability of meeting the primary endpoint. There were some early nice signals in it, and I think there will be lots of interim analysis looking at the data set to see what we can glean from the patients who were recruited to date. But it's important not to continue trials past their endpoint if they're not going to meet that endpoint. It's also important to think about what endpoints we use for clinical trials, not just alkaline phosphatase, but thinking about whether or not we incorporate MRI or other markers of fibrosis that are not liver biopsy into our endpoints. The next study looks at nor-ursodeoxycholic acids. That's a NUC5 study. And I guess the highlight just to say here is we know again in this phase 2 trial, there was a dose-dependent reduction in alkaline phosphatase, which we could see here on the left-hand side. And actually, even though this recruited patients who have a high alkaline phosphatase, we've now managed to complete recruitment within the UK, and we're in the open label extension. And for this endpoint, we're looking at both alkaline phosphatase and also a lack of worsening of fibrosis on histology. So slightly different endpoints to the previous study. And as I say, we're now in the open label extension. So we've managed to recruit to target, thankfully, within this study without having any safety signals. The other two studies, just a headline, I include the one where we look in a phase 3 trial at bezafibrate plus ursodeoxycholic acid versus placebo plus ursodeoxycholic acid. We know that bezafibrate activates all of the PPAR subsets. And the open label study earlier on suggested that it can reduce alkaline phosphatase, and we know it has a very positive effect on pruritus in terms of itch. This is predominantly recruiting from France, so there's 35 different French centres, and the outcome measure is again alkaline phosphatase, and recruitment is still open and ongoing. And again, just highlighting the importance of fibrates in PSC from the Fitch trial, which was a double-blind trial looking at both PSC and PBC patients. If you look on the left-hand side here, and you can see the visual analog score for itch, you can see that patients who had PSC compared to placebo patients did much better in terms of their itch score on bezafibrate compared to placebo over a short period of time. And again, that's exemplified in the graphs here. And it's again why it's made the EASL guidelines with regards to first line for itching at the moment in the context of PSC. Looking at the long-term effect of simvastatin, again, this is a long-term study, and we talked about it being over 5 years. And this is to evaluate if simvastatin can prolong survival free of cancer, variceal bleeding, or liver transplant. Again, the inclusion criteria are very broad, and we are continuing to recruit to this study. The end of study is at 60 months. And there are a number of good clinical trials that are open at the moment. There's 106 studies currently listed on the website worldwide for PSC. both in terms of treatment, in terms of clinical outcomes, and also in terms of symptoms. And you can see here on the map the sites that are potentially recruiting, and on the right-hand side, the current studies that are recruiting now, and you can click on each of these individual studies and see what's open and where you can potentially get referred to, and studies that are upcoming that may not be open to recruitment yet, but we intend to open soon. Next, just to target the other big thing, which was about symptoms, and there was a lot about symptoms, particularly pruritus, but also a little bit less about fatigue and brain fog. It was both in cholestatic diseases with regards to PBC as well as PSC, and it was highlighted particularly at the BSG. And there was some interest really in these IBAT inhibitors, which are basically inhibitors that block the uptake of bile acids. And it's thought that the bile acids are part of an overall systemic response, which might be increasing the pruritus in the context of PSC. So it might be the thing that's contributing to the itch, even though it's certainly not the only thing. And this helps to actually excrete the bile acids within the feces. So you do get a little bit of diarrhea with these medications, and also put it into the kind of main intrahepatic circulation. So there was some published data from 2022 in HepComs with regards to maralixibat, which is one of the IBAT inhibitors, again looking at the overall itch score over a period of time. And you can see that the itch score over a 14-week period gradually reduced in this study of 27 patients alongside bile acid reduction, with the main treatment side effect in 50% of patients being diarrhea. And now we have Vistus Open, which is a clinical trial, again, looking at volixibat. And this clinical trial specifically is interested in itching with lots of secondary endpoints, including patient-reported outcomes, but also looking at progression of disease, cholestasis, fibrosis. And the randomization is into 2 different doses of volixibat compared to placebo. And as I mentioned, it's open now to recruitment with regards to patients who specifically have itch. So I think it's important as a patient, if you are itching and you're not controlled by standard therapy, to think about whether you'd be interested in contributing to this clinical trial. You do not need a high alkaline phosphatase in order to recruit. Other thing I want to mention is the big thing about the gut microbiome in the context of PSC, and there's been lots of interest in that recently. We know that there's different diversity in the context of PSC compared to IBD alone, and also compared to what we would consider to be the healthy population. In fact, there's a decreased diversity within PSC alone. And I've listed some of the classical microorganisms and pathogens that we tend to see in the context of PSC versus IBD, even though that does necessarily differ, depending on what we look at, whether we look at stool, whether we look at biopsy specimens themselves, whether we look at sort of metagenomics. There's a study called the Dynamics in PSC at the moment, which is particularly interested in looking at the microbiome in the context of PSC, and that's currently recruiting in Oxford, and again can be accessed through PSC support. And there's been a number of studies looking at antibiotics, such as the vancomycin PSC VANC study, which has just completed recruitment, and again taken a small number of patients and given them vancomycin over a period of time, looking particularly at fecal bile acids and also biopsy samples, on the premise that we know that vancomycin and other antibiotics can actually reduce the alkaline phosphatase in patients with PSC. The key concern being of antibiotic stewardship and making sure that we don't get resistant entococci that emerge. And so we have some early signals there that the alkaline phosphatase is getting better, but definitely the diversity is decreasing in patients who are on vancomycin compared to not. So how do we increase that fecal diversity? Well, then we moved on to fecal transplant, which has been used for other conditions such as Clostridium difficile, and also in other conditions outside of that and other autoimmune conditions. This was an open label pilot study that was published a few years ago, just to really say that giving fecal microbiota transplant was safe, and a single inoculation increased diversity. And you can see this increased diversity with different donors on the graphs down here below. And now actually there has been a ward called the Fargo trial that will be opening in multiple different sites, looking at fecal microbiota transplantation over a longer period of time. So giving multiple FMTs rather than giving a single inoculation, and seeing whether those multiple FMTs over a period of time and actually assessed over a longer period of time, over a year's time, can actually change not only the bacterial diversity, but has an impact also on cholestasis, potentially on fibrosis and a number of other secondary outcome measures, including symptoms. So as I say, one of the big things that we're all concerned about is cancer. And there were a number of talks about cancer in different formats. I've just taken a couple of main highlights. I think at the moment, the main way that we look at cholangiocarcinoma, which is probably the most feared cancer, is by doing imaging, which is MRI imaging or ultrasound imaging, by doing very non-specific blood markers, such as the CA19-9, which is a tumor marker, which we know has massive frequency and fluctuates in patients who have jaundice, who have high bilirubin, who have cholestasis, and also sometimes in health. And we also take biopsies, or what we call cytology, and samples at the time when we're looking at either dominant strictures or when we're looking at an area that's narrowed. And what we want to try and do is predict those patients who might develop cholangiocarcinoma on the background of PSC, and also try and work out whether these strictures might be benign or malignant before we go in there. And there was a nice talk by Annika Bergquist, who has given some lovely talks in the context of surveillance and cholangiocarcinoma, really looking at the recommendations that EASL has made with regards to doing annual ultrasound and or MRCP scan. And in their nationwide cohort, they were doing MR scans plus what we call gadolinium contrast, so HPB contrast, and they had almost 2,000 MRCPs, 90% of whom had contrast. And I think one of the highlights I took from that is, in actually the whole population, only 2% of those patients actually developed hepatobiliary cancer. So it was a tiny proportion, and that includes both cholangiocarcinoma as well as gallbladder cancer and HCC, so primary liver cancer, over a follow-up period of 60 months. So there was a low incidence overall of cancer. The CA19-9 level fluctuated, so this tumor marker is not a good way of being able to detect it. So I'm not sure that measuring it really particularly helps. And I think the other thing to say is the majority of patients who turned out to have cholangiocarcinoma did have symptoms. So they were jaundiced, they developed cholangitis, they were very fatigued or not feeling well or losing weight, as opposed to those patients who developed a gallbladder cancer who was asymptomatic, and that was picked up on ultrasound when they saw a small polyp or a thickening, which is often what we do on a yearly basis. And importantly, 62% of these patients, when found, were eligible for curative treatment. So the actual summary, I think, from her presentation very much was actually by doing yearly MRCP scans with gadolinium, I don't think she felt, or the audience felt, that actually she picked up any more cholangiocarcinomas or any more hepatobiliary malignancies than you would have done if you were basing this on symptoms alone, even though obviously the annual gallbladder surveillance is a very different question, because that picks up early polyps in those who are asymptomatic. And I think that's an important message. And then we had some lovely presentations by Jesus Benalis's group on the day when actually Palak Trivedi was chairing, looking at some of the molecular diagnostics that are being developed for cancer detection in the blood. So a kind of real biomarker looking for cancer detection, not just based on MRCP. And this was looking at how the DNA is what we call methylated, which is kind of broken down into its subsets, how the environment might potentially change those. And it was also looking at the different proteins within the blood and also the different metabolites within the blood. And there were 4 really nice studies that were presented, whereby in each of them, there were 3 or 4 different biomarkers that were created where we might actually be able to see a signature there that predated the development of cholangiocarcinoma in patients with PSC. So I think that there were really exciting data, really interesting data, and all of it needs to be validated. But it was the first time I really felt that we were making significant progress, not just in cholangiocarcinoma research, but more importantly in PSC cholangiocarcinoma research, in terms of being able to get earlier detection. And particularly as we know that the liver transplant indications have increased now to include patients who have dysplasia or peribiliary cholangiocarcinoma, you know, that's a significant step forward. So take-home messages for EASL and BSG for me very much is, you know, PSC is now a really active area of research and is very optimistic in terms of clinical trials and those that are available, not just in the UK, but worldwide. It's not just looking at clinical outcomes, it's also looking at symptomatology. I guess our current goals is to really identify those patients who have got itch and have got significant symptoms and make sure that we're dealing with those appropriately, and particularly recruiting to clinical trials where appropriate. Having early treatment of any signs of bacterial cholangitis, including endoscopic dilatation and antibiotics. I didn't discuss that data because there was too much to discuss today. thinking about cancer surveillance strategies and how we use these blood-based biomarkers, these kind of liquid biopsies in our current strategies rather than just annual MRI, and thinking about our expanded transplant indications and early referral for our patients as appropriate. So with that, I'd just like to stop talking and open the room to questions. Thank you.
Thank you. Thank you so much, Dr. Culver. It seems like you came away from that conference, and I certainly came away from that conference with hope that things are really moving forward now. So I'm sure that will be very interesting for everybody on this webinar. A couple of things that just struck me. I wonder if everybody understands endpoints. You might do, but I thought maybe it might be a good, you mentioned them quite a few times there, it might be a good idea just to explain those.
Yeah, so when I talk about endpoints, I guess what I'm talking about is what we are interested in the context of clinical trials to tell us that something is working appropriately. And there's many different things we can look at. We can say, is it working appropriately because somebody who is very itchy is a lot less itchy? And can we, rather than subjectively do that, can we do that on a numeric scale or on a visual scale to give us an objective idea of how much that's improved over a period of time? And that period of time could be 12 weeks, could be 28 weeks, could be 2 years. The next thing we look at is obviously cholestasis, which is our liver biochemistry. So what I look at, the blood tests which come up in front of me. And the particular blood test we're obviously interested a lot of the time is alkaline phosphatase, and we talk about that a lot. But we're also interested in the transaminases, so the ALT and the bilirubin level, and sometimes the other markers of synthetic liver function. So those can be what we call an endpoint, so something we want to measure because it's objective and we can see it over time. And then the other things we talked about before, which I talked about with the phase 3 trials, is moving one game higher than that and saying, I don't just want my blood test to get better, I want this to make an impact to my patients in terms of either their survival or clinical outcomes. And that's difficult because that's over a long period of time. We've seen that clinical outcomes can take a long period. In other words, to develop an infection, to develop scarring that might equate to cirrhosis of the liver or any complications of that. So sometimes we just look to see whether or not there is progression of the scarring of the liver, so what we call fibrosis. And that can either be done as a stage, looking at a biopsy, or actually non-invasively, we could look at that with a fibroscan, so we can see a point go up or down, even though there is some subjectivity there, or what we call an ELF score, which is measure 4 components in the blood. And again, it gives us an idea of kind of fibrosis load, as well as sometimes systemic inflammation. So endpoints are just something that we determine that gives us an idea between 2 different periods of time, whether something has been effective or not.
Great, thank you very much. I'm sure that was helpful for quite a few people on the webinar. You mentioned the increase or the forecasted increase of people with PSC and IBD, and somebody's asked, what about the predicted forecast for those with PSC without IBD? Was there any mention of that at the conference?
Yeah, it's a really good question, isn't it? So
yeah.
Interestingly, a lot of the data is attached to the IBD data. So the stuff that was actually talked about at EASL and the things that were presented actually related to PSC and IBD specifically, rather than separate to it. I mean, I think in general, we know that PSC, irrespective of whether there is IBD, and obviously we know IBD can develop over time as well as predate it. There is a general appreciation that there is an increase overall in primary sclerosing cholangitis and other cholestatic and autoimmune conditions, probably from the same factors that drive PSC and IBD as a unit. But I can't really comment with regards to numbers because that wasn't presented at the conference.
Okay, thank you for that. So I'm going to we've had some questions specifically about research, but also generally about PSC. I'm going to take the research questions first, if I can, and then if we get time at the end, we'll take some general questions as well. We always get the general questions because people obviously have a lot of questions about the condition. So the first question, it's about somebody's interested in the balance of the split of research. I already participate in drug trials, research, etc. But what I don't see a lot of is research into the actual causes of PSC. So ask this is the question. As with other diseases, if we can understand the cause, we should move closer to a cure. Is there nothing going on in this space?
Yeah, very important question to ask. I mean, I actually think over the last decade, there has been lots of work trying to look at a cause, a single cause, and also multiple different causes, which has focused both on genetics. And there has been some lovely genetic work, both from the UK and from Europe, highlighting different genetic polymorphisms that might be important in the context of PSC, but also in terms of environmental exposures, and of course, microorganisms, which is one of the reasons we look at the gut microbiome. So I think there is a lot of work in that. I guess, like everything else, it would be great if you could find a cause that you could potentially reverse or take away, and therefore prevent the disease from developing. And I guess that's one of the reasons why we try and look at kind of early PSC or patients who develop it at a much earlier stage to see if we can find that. There hasn't been huge breakthroughs in terms of one cause, but we do know about the aberrations of the immune system that potentially can drive a PSC phenotype. In other words, inflammation of the bile ducts and stricturing of the bile ducts, which we class as primary sclerosing cholangitis. We also know about the pathways that drive fibrosis that can drive the underlying fibrosis of the disease. What we don't necessarily know is exactly what triggered that off, but we always say that that is in an appropriately genetically susceptible patient with the correct kind of microbial or environmental trigger.
Okay, thank you so much for that. So I have a question here that was sent in before the webinar started. In your opinion, when will we see some stronger data to create better treatments for PSC?
I think we are creating them already, if I'm honest about it. I think, if I look back at when I started working in the kind of PSC or cholestatic liver field, which was, well over 10 years ago now, there was no interest in research in clinical trials in PSC because not only was it a rare disease, but as we mentioned, no one really knew what caused it, and people weren't interested in trying to find a treatment. And that has completely changed now. In terms of how long it will take, obviously a lot of these studies, as we talked about, phase 2 give us 12-week or 28-week data, but they don't necessarily give us long-term data. And so what we really want to be able to do is look at that long-term data and say, actually, the drug that we're going to give you is safe and it really has an impact in your disease in the longer term. And that takes years, sadly. So will it be years until we find a drug? Not necessarily. There might be drugs that are repurposed from elsewhere. And there might be drugs that we find that actually turn out to work really nicely. And some of the phase 3 data that's coming out now, could be, in the market and could be given in the next sort of 12 to 18 months. But realistically, I think we're looking at short years until we actually see a drug where it's going to make a huge difference.
This is thank you, Dr. Culver. This is quite a technical question. In the presentation, more precise in part where Dr. Culver mentioned phase 3 studies, the 2 studies, now I've got to try and pronounce this, Bezleclair and Piscatin, have the same NCT code, which I don't even, you might have to explain, please, what the NCT code is. And the question is, are they really part of the same study?
No, they're not part of the same study. So if they had the same NCT codes attached to them, that's a mistake with regards to the presentation itself. So they're not the same study, they're different studies. One of them, as I say, is predominantly from the French cohort, looking at bezafibrate. And the other one is very much looking at statins in terms of, outcome. And I mentioned again, survival with relation to kind of cancer without transplant and other liver-related complications. So separate studies, and I'm sorry if they have the same NCT code.
Okay, it's very well spotted if somebody spotted that. So somebody's asked the question here, I have PSC alone, so without IBD. Is there any research with regards to pain?
Okay, so I suppose the first question with respect to pain is there research with respect to it? No is the honest answer, but I guess the question is why have you got that pain? And I think we have to sort of think a bit outside the box here. We know that patients who have PSC with or without IBD can have right upper quadrant pain. I guess we go through the protocol really of working out in individual patients if there is something that is prompting that pain, making sure that they don't have worsening strictures by looking at their MR scans, making sure there's no underlying cholangitis, so little bits of infection that are on and off. And if we can't find an obvious cause, and obviously looking at other causes that might cause pain, thinking about how we can treat that with regards to pain relief And that can take the form of antispasmodics or nerve agents, as well as your kind of traditional, paracetamol. So there's no direct research that looks at pain directly, but there's lots of clinical trials that look at how drugs might improve patient-reported outcomes, and pain, along with fatigue and along with itch, are one of those outcomes that are looked at.
Yeah, thank you so much for that. Question here. Thank you. Well, comment first. Thanks for a great update of the Vienna Liver Conference. Do you have any thoughts you would like to share about the pipeline medicine from Chemomab and High Tide?
So, I mean, I didn't actually mention the Chemomab study there because there was no specific highlights from EASL, at least that I saw with regards to it. I mean, it's an open, actively recruiting study at the moment. It's called the Spring Study. It's recruiting patients to a kind of a chemokine receptor that is, potentially important in both inflammation and fibrosis in the condition. There are intravenous infusions. The protocol itself is a little labor intensive, but actually is a nice protocol because we get to see patients, we get to see how frequently they have their infusions, and we get to see their liver function tests in real time, which is a bit more difficult when you're giving an oral medication and patients are away. So what I would say is, I think it's a really exciting program. I think there is a good potential for the drug to potentially have a significant impact. I like the fact that, as I say, there are IV infusions and it's a relatively short period of time with regards to being in the trial, and there's an open label extension thereafter. And even though I didn't list it on the slide because there was no updates from EASL, it's one that I would definitely be encouraging people to recruit to.
That's great, and that's on our website if anybody wants to have a look at that as well.
Yeah.
Next question. Are there any trials which look at treatments of both ulcerative colitis and PSC together? Has it seen some treatment conflicts and masks symptoms?
Yeah, so most of the trials that are designed to look at PSC, of course, prefer your inflammatory bowel disease to be either quiescent, so that's not active, or that you haven't changed your treatment in the 8 to 12 weeks before it. And that's just because a lot of medications that are given for inflammatory bowel disease can have an impact on liver function. So whether that is vedolizumab, infliximab, tocilizumab, lots of drug names there, but all of them actually can have an impact on the liver function test, particularly in the first 4 to 8 weeks after changing that medication. So we always actually look as a secondary endpoint at effects of inflammatory bowel disease on PSC medications, and actually vice versa a lot of the time as well. So there's been studies looking at, for example, vedolizumab that are given for inflammatory bowel disease and how they might affect the cholestatic markers of PSC or the imaging in PSC, and the same for some of the other drugs that I've mentioned. So I think we do actually look at them. It's very difficult to put a dual endpoint there, which is both the outcome of the IBD and also the outcome of the PSC, because sadly, as you well know, they're not a complete correlate. Just because, one is severe doesn't mean that the other is, and vice versa.
Yeah. Okay, thank you for that. Do you have any further information on the phase 3 trial for Noyes? I can't say it. So yeah.
Yeah.
For example.
Yeah, go on.
No. How long will the trial continue? Have there been reports of interim outcomes?
Yeah, so nothing that we can disclose, sadly, in this kind of environment. So as I say, it's close to recruitment because it reached targets. It's in its open label phase, which is fantastic. But actually nothing that the company would be happy to disclose at this point.
Okay. Thank you for that. So I'm going to ask some general questions. We might come back to research, but I think I've asked most of the research questions. How do we check we have polyp? How do we check we have polyp tests? Is it during colonoscopy?
Yeah, that's a really good question. And yes, the answer is yes. So for patients who have PSC alone without inflammatory bowel disease, everyone should get a colonoscopy at some point, usually what we'd say at diagnosis, and then actually every 5 years thereafter, just to make sure that there's not microscopic evidence of inflammatory bowel disease plus minus polyps. In patients who have PSC and inflammatory bowel disease, we advocate having it on an annual basis. And at that time point, most patients should have a dye spray colonoscopy. So you get blue dye sprayed, and that gives you an increased detection or an increased ability to see some of the polyps that are really flat to the mucosa. And what your colonoscopist will do is then take those polyps off and send them to the lab so they can be looked at, just to make sure there's no abnormal changes there. Sometimes you also get samples of areas of your bowel that are not polyps, just to look for disease activity, and also any areas that look slightly abnormal, just because sometimes you can get some inflammation and we want to make sure that there's nothing growing there. So that's when you pick up polyps at a colonoscopy.
Okay, no, that's really good answer. Question is about research, actually. What does whole gut shotgun metagenomic sequencing of someone with PSC show regarding differences between individuals with a PSC and without?
So, and the whole point of kind of whole or shotgun metagenomic sequencing is really to kind of look on the DNA level, to look at the individual organisms and actually the genes within those organisms, and look at diversity. And to my knowledge, very similar to looking at what I showed you on the PCA plot before, actually there's a reduced bacterial diversity overall in shown in shotgun sequencing as compared to other sequencing in patients with PSC compared to PSC IBD. And there is a list of different pathogens that you can potentially see that are either increased or decreased in the context of PSC versus PSC IBD. And they've been published, and I mean, you can look those up. I'm not sure, you can get that from a research perspective. So from a research lab, you can do shotgun sequencing. I believe probably even privately you could pay for it, but I'm not sure at this moment in time it changes anything we do in terms of management, either in terms of advocating probiotics, for example, or advocating giving FMT to increase bacterial diversity. I think what we don't know is how to necessarily interpret the answers to that and how we will potentially change management as a result.
Okay, thank you for that. So somebody here has a 16-year-old. Any advice or suggestions for pain management in a 16-year-old with PSC? Paracetamol and codeine are not effective. I can just imagine how distressing that is for the parent. I presume it's a parent or a carer who's posted that question.
No, and it must be awful. I mean, I guess what I would say, similar to what I said before in terms of thinking about what's causing the pain, I think the first thing is just making sure that you've, with your healthcare professional, have thought about, the reasons behind the pain in the first instance. So just making sure that they've had an up-to-date scan of their liver, whether that's an MRI or an ultrasound, making sure that there's no, small stones or sludge that's actually causing the pain, making sure that there's no new strictures that's leading to the pain or anything else that might be causing it. Or their inflammatory bowel disease is well controlled if they have it. Things like Buscopan, which can help with spasmodic pain, are safe in children of that age, not usually less than 12 years old, but in someone who is 16 years old. And spasmodics can actually really help with right upper quadrant pain. Things like amitriptyline at very low dose can as well. Again, not advocated for young children, but at the age of 16 would be okay. And again, that's nerve-related pain, particularly related to the sphincter that can sometimes contract, particularly with the opioids that can be worse. So that would be the kind of path that I would be looking at. But firstly, just making sure you've excluded all the reasons why patients might have pain, and even thinking outside the box of things like, celiac disease and thyroid and things that can coexist in people who have autoimmune conditions that can also cause abdominal discomfort.
Thank you very much for that. This is a question about somebody who's got other conditions as well as PSC: menopause, osteoarthritis, diabetes. What should we as patients do if we have other conditions? They're all separate, and getting the right care that doesn't long-term negatively impact the other conditions. So treating one condition that doesn't negatively impact the other condition. As a joined up treatment plan is near impossible, as GPs don't have the skills and medical professionals can operate in silos. What can patients do to mitigate that?
And I think one of the things that patients can definitely do, and it obviously sounds like this patient is be well educated, understand their conditions, understand the medications. And whilst they can't be their own doctor, they can come, fully armed with information that they can give their practitioner. One of the hardest things for a doctor actually is when a patient comes and can't remember the medications they're taking or the doses of them, and there's a bit of a disjointed history about their background, which is no one's fault, but it's very difficult then to marry it up. And you're right.
Can I just ask you a question there, Emma? Aren't there records available to all doctors to have a look at?
You would wish, wouldn't you?
Yes.
So I think the honest answer to that is that sadly, the electronic records, particularly from different centres, don't always marry up. And what you will get is information from a GP that's hopefully usually in date, but maybe from another practitioner elsewhere. So it could be that they're referred from another trust, particularly as a tertiary referral, so someone who's kind of come for an expert opinion. Or it might be that they've been managed by someone else along the way, but not in your local area. And so all the information isn't to hand. And so actually, when the patients are either a new referral, or even if patients are known to you, we really rely on patients to be able to say to us, actually, this is the drug that's changed. Because sadly, the systems just don't marry up. And it's not just where I am. I know it's the case across the country. Yes. And the perfect solution would be to marry all of that up electronically, but it just doesn't happen. So that's the first thing. That hasn't answered the lovely man's question, however. And I think what I would say is that actually, so firstly, when it comes to clinical research and studies, we take account of all the other things that are going on. And there are definite exclusion criteria, but things that you've mentioned are not usually within them. So it's usually medications you're taking, not necessarily comorbidities, unless that's significant renal disease. And secondly, whether we realize it or not, a lot of the things do overlap. So things like obviously osteoporosis and PSC are intricately linked because cholestatic liver diseases cause thinning of the bones, and thinning of the bones is indeed osteoporosis. So one of the causes will be related, no doubt, to your PSC. And so actually your PSC doctor should be able to help manage your osteoporosis, not just by suggesting medications, but also by working with a hospital specialist if you need a special medication yourself in order to be able to get that medication for you. So I know that we do work in silos sometimes, but I think if you can be the advocate that brings everything to the table, then those specialists should have the opportunity to be able to marry that up for you.
Okay, no, that's a great answer. We've got a question here on what's the purpose of monitoring bone density, but I think you've just answered that actually.
Yeah, so but it's an important one actually, and I think that's exactly it. It's because of cholestasis. So because of, when I say cholestasis, what I mean is elevated ALP and also gamma GT in your blood, which causes cholestasis. So it causes a slowdown of the bile acids. Increases your risk of having bone disease, and that's thinning of the bones. So that's why we do the bone density. It's why you will often get vitamin D and calcium supplements. It's why we check your vitamin D levels irrespective of that, and why we replace it so that we prevent fractures.
Okay, thank you. Question here: if a patient is prone to severe pancreatitis after ERCP with up to 2 weeks stay at the hospital and necrosis in the pancreas, is there any indicator of how the outcome will be post-liver transplant?
Oh, so not to my knowledge in terms of transplant. I was going to say, I'm really sorry to hear that. That's awful. And, it can be a really torrid time, with what we call iatrogenic pancreatitis, so an ERCP-induced pancreatitis. I don't think there is any, to my knowledge anyway, any direct link with whether or not you get pancreatitis and your outcome at transplantation. The key things for the transplant physicians is when you're having pancreatic inflammation, for that to be completely at bay. So in other words, the inflammation to have resolved, any cysts that might have been created to resolve, and importantly, the blood vessels that supply the pancreas and supply the liver to be open and working successfully. Because actually that's more of an indicator of how things will go with regards to transplantation than whether or not you've actually had ERCP-induced pancreatitis itself. So it's just getting over that pancreatic inflammation, and obviously treating the pancreatic inflammation, making sure you're taking some enzyme supplements so you don't lose weight and you don't malabsorb those vitamins because the pancreas is not doing its job effectively.
Thank you for that. Now this question is research related. It's quite long, but I am going to read it out. Sometimes in oncology patients are given experimental treatments as a last resort. This is, of course, not the same as PSC. Could non-cancer PSC patients in the future be given medicine not on the market if they choose to, if the patients are not qualified to participate in trials? For example, medicine that showed good results after phase 2 trials such as Norurso if pharmaceutical companies are willing and patients accept the risk. What are your thoughts on this?
Yeah, so I understand. So if you can't take part in a clinical trial, either because you're ineligible, sometimes patients have overlap or they have other contraindications, then I guess down the line, you'll be thinking about taking medication. I guess that's the case for, for fibrates in some situations, because we don't have phase 3 data on fibrates, and yet we're using some small studies on fibrates to guide our itch management, knowing that alkaline phosphatase improves. And so actually my method there is to say, actually, if a patient is eligible for a clinical trial, I would much rather put them on a clinical trial. But actually, if they're not eligible or don't want to take part in a clinical trial, I would offer them a fibrate as a second line for exactly those reasons that you've stipulated, because there's safety data there, because actually I think it might potentially work both to improve their alkaline phosphatase and to improve their itch, and because I don't lose anything at the moment in terms of clinical trials. So I think as long as there's good data to support it and there's no safety signals and the patients can't participate in clinical trials, then, as long as it's guided by your healthcare professional, I always have to say that, then, that would be appropriate.
Okay, it's very nearly 8 o'clock. We still have quite a few questions and we're not going to get to them all, I'm afraid, but I'll ask you a couple more if that's okay. So my husband is UC and PSC. What are the stats of my daughter developing PSC also?
Oh, okay.
I'm a worried parent, I would say there.
Yeah. So it's a bit simpler for ulcerative colitis itself on its own, as opposed to PSC and ulcerative colitis. Obviously, we know that there's an increased risk of autoimmune conditions coalescing together, but there's not a definite percentage that I can give you with regards to whether or not your daughter would develop it as opposed to not develop it, because there isn't that percentage that exists. So autoimmune conditions, can carry in families. PSC can carry in families, but there isn't an absolute percentage that's available to be able to predict your daughter's risk of PSC in the future.
And this is going to be the last question. It was asked quite early on and I've only just got to it, so I will take it now. And I think I know the answer to this. Is part of the problem that there aren't enough PSC experts within local and regional hospitals. Therefore, there is a reliance on expertise at the specialist centres, which I know Oxford is one of those specialist centres. But what about the outlying areas?
Yeah, so that's about education. So I think you're completely right in what is a very challenged NHS. It's very difficult for one hepatologist or two hepatologists in a district general hospital to be able to be a subspecialist in every kind of area. And even if you manage lots of PSC patients, and obviously we do here in Oxford, actually being able to be an expert and knowing all the upcoming research and all the upcoming information is a challenge. So I guess, again, it's about education. So what we do within the Thames Valley region is we have a monthly autoimmune MDT, and our colleagues will call into that so that they can not only hear about what might be up and coming with regards to cholestatic and autoimmune liver diseases, but also so they can talk about difficult patients, or they can talk about challenges they had. And that's actually really important. It's important to understand what's happening within our district general hospitals, but it's also important because actually it engages in a two-way conversation, so we both learn about the populations we're looking after. And I guess I would encourage, physicians to engage in that education, but patients also to have that information to hand. I've just listed the things that are important from the EASL website that we know that we should be surveyed on, and maybe PSC support with us can create a list of those things. So you can go to your doctor and say, actually, these are the things that I would just like to make sure that you're checking. And I'm not saying that you have to educate your doctor, but what I'm saying is it's not wrong to say, actually, I just want to make sure that these things are ticked off. And if I'm not having them, I'd like to know why. And I think that gives you the power to be able to do that in a non-confrontational way so that you can manage your care as well.
I think that survey that you quoted from EASL about what people should be having and what they're not having, or some people are not having it, which Martine Wormsley, who's a staff member of PSC support and run PSC support for a very long time, was the lead author of that. So very proud of that. I think that's a basis for people advocating for themselves as well. But thank you so much. Thank you so much, Dr. Culver. And I'm sure you'll join us again. I know you're very generous with your time, but thank you on behalf of everybody for giving us a very good introduction on research, current research, and answering at least most of the questions that we've had this evening. And thank you everyone for taking the time to join this session. Dr. Culver will be speaking in person at our Information Day in Oxford on the 30th of September, alongside Dr. Simon Rushbrook and Dr. Deepak Joshi. So it'll be an excellent event for those of you who would like to join us at that in-person event. And I just wanted to mention a couple of things, and that is PSC support has committed £1 million. We are going to commit £1 million to research as part of our Mission 2030 to try and really move forward the dial on finding effective treatments for PSC. And also, I wanted to say that, just a reminder really, and I know we've mentioned it once already in the session, that all the clinical trials available in this country are on the PSC Supports website. So please take a look at those. Our next session, our next webinar, our next Ask the Expert webinar is on the 27th of July. It's a lunchtime session, Thursday, the 27th of July, between 1 and 2 p.m. We move these sessions around. So if people can't make evening sessions, maybe they'll make a lunchtime session. If they can't make weekday sessions, we sometimes have them on a Saturday. So look out for those. It's Dr. Jess Dyson, the next one, based in the Newcastle Hospital. And it's a general PSC questions and answer session, which I know we always get a lot of questions at those as well. So thank you, Dr. Culver, once again, and thanks everyone for joining us. And I hope you have a nice rest of the evening. Bye-bye.
Thank you. Bye-bye.